run through of the therapy notes. This is the fast one where I don't really give you time to write everything down. You would already have the notes by now. Look on the screen, look on your notes, make sure you got everything where it should be. All right, so talking about the types of treatment, there's two parts to this slide presentation: psychotherapy and biomedical. Psychotherapy is like counseling therapy, and biomedical things like drugs and medical treatment. So starting off with psychotherapy, you got yourself a crash course. Make sure you watch that. And then we break down the psychotherapies into four main types. I guess technically 5 or 6 because there's several that go together here. Let me move that out of the way. But kind of really 4 main types. So psychoanalytic, psychodynamics up first, then humanistic, then behavioral, then cognitive, and it was cognitive behavioral as well. So that's how you could get 6 technical, but really 4 big groupings. Psychoanalytic, psychodynamic is 1, humanistic is 2, behavioral is 3, cognitive is 4. The eclectic approach is that thought that like you do a bunch of things at once. You don't just do behavioral, you don't just do psychoanalytic, you can do behavioral with cognitive, with some drug treatment or stuff like that. And you kind of mix it up between all the different types of therapies in this Google slide that we'll talk about. And most therapists actually do this. Most people suffering from psychological disorders find help from this. Like they'll take an antidepressant and do, like psychodynamic therapy for their depression or something like that. So there's usually a combination going on. Very few people are just solely one thing and that's it. So that's the eclectic approach. So psychoanalysis is up first. If you did not watch the video where I broke it down so that you could write, I want to make sure I make this really clear for you, all right? Back here. Psychoanalytic is psychoanalysis. It's a version of the same word. And psychodynamic. These are actually 2 different things. And so you'll have to note in your notes when the Google slide changes, if you were writing them down and not listening to me tell you the difference. Psychoanalysis, the psychoanalytic approach, is the older approach. It's the first approach to psychology, but it's not really used today. Psychodynamic is a similar approach, and it is the one that is used today. And you'll kind of see why when we go through it. So psychoanalysis, like I said, you're going to be pretty hard-pressed to find someone today who would actually use this type of therapy. But it came from Freud. He was the first, psychologist to bring psychology to the forefront. He's not necessarily the father or anything, but he's the one who makes it popular. And so he really gets a lot of credit for the books he wrote and stuff like that. And in the books he wrote, he talks about the psychoanalytic approach and psychoanalysis. He talks about free associations, resistances, dreams, transference, kind of all that stuff that maybe people don't really actually do today. He said people could live a healthier, less anxious living, and that we don't really know ourselves. So in psychoanalysis, it'd be like them introducing us to ourselves. So that should say the goal. I need to go fix that. And take little notes of where all my mistakes are so I can go fix them. All right, sorry. So because I have several little typos through here and I gotta remember where to go fix them. Bring into conscious awareness things that were repressed. So if something's repressed, it's in your unconscious, you do not know about it. It is not anything you're aware of. So it'd be like you have this psychological disorder, but you don't know why because it's repressed and it's not in a part of you that you can get to. But if you do these things on the next slide, it will bring it to the forefront for the psychotherapist to figure out and kind of analyze and then like let you know, like introduce you to it so you can figure out how to like bring it into your conscious awareness so that you can then, fix it. So it emphasizes the power of childhood in molding the adult. And he used something called free association. So make sure you got that definition down. That's where the person says anything that comes to mind. Anything and everything that comes to mind, they're just kind of blurting it out, no matter how trivial, stupid, embarrassing, significant, insignificant, whatever you think. So here's kind of how it works. You've probably seen things like this in pop culture or something like that, where the person lies down on the couch. The psychotherapist is like behind their head, so they can't really see them because they're kind of looking one way and the psychotherapist is behind them. I feel like they're sitting in a big chair, probably got their legs crossed with like a book, and they're just taking notes. And the person does free association, just starts saying everything. Now, if the person forgets, quote unquote forgets, or you can tell they're like editing it or they're like tiptoeing around it, they don't really want to say it, maybe they're fudging, lying because it's embarrassing, it's, whatever, he would call these things resistances. And so the psychotherapist would note these resistances. If the person was talking about like a bad relationship with like their mom or something like that, and then they started kind of taking it out on the therapist, or they were talking about this like their marriage or something, then they start having like lustful thoughts for the therapist. Anytime they like take whatever the thoughts and emotions are of what they're talking about and put it on the therapist, that's known as transference, basically. And then basically the psychotherapist writes down all this and can kind of get all this information out of the person's unconscious, all this like repressed stuff the person doesn't know. And they then interpret it. And that's the interpretation. And then that's what they bring back to the client and, kind of say, well, like, here's your answer. Here's how you fix yourself. Here's all that kind of stuff. So here are the definitions of resistances. Like I said, it's anything that's kind of anxiety provoking. So people don't really want to talk about it. Interpretation is what the psychotherapist or psychoanalyst, kind of same thing, makes of things, what the person says, their resistances, when they talk about their dreams, when they talk about significant relationships or behaviors or events, stuff like that. Transference is when the patient transfers their feelings or emotions that are linked with something they're talking about, some other relationship, to the therapist. And like I said, few therapists actually use this today. It'd be a pretty difficult task to find someone to treat you in therapy in a psychoanalytic way. But it was really common in the beginning. It's some of the groundbreaking, bringing psychology to the forefront, kind of first major type of therapy. It's definitely worth noting about and learning about, but it's not something that really exists. Today, if you note on the screen, make sure in your notes you see that we're now changing to the word psychodynamic instead of psychoanalytic. Today, there are people who said, some of what Freud said makes sense. Maybe, what happened in someone's childhood that really is affecting the way they are. Or, maybe there's some unconscious stuff, rumbling under the surface that they're not really aware of. And if I could help bring it to their attention, they could kind of fix what's on. So you could find someone to treat you in a psychodynamic way, psychodynamic therapy. And some of the stuff Freud talks about a lot, which I didn't put back in the notes, but you'll see when we get to Unit 7. So Unit 7 that we're going to do next is all about personality, which is all about psychoanalysis that you just touched on just a second ago with Freud. And then the second part of Unit 7 is motivation and emotion. And that's going to be all on humanistic, which is the next type of therapy coming up in just a few slides. So you didn't really have a huge background information, like background knowledge on those two, but it's okay. We'll talk about it more in Unit 7. And when we get into Unit 7, which you'll see when we talk about psychoanalysis and personality and Freud, is he also talks about a lot of sex. And so a lot of therapists were like, some of the stuff that Freud was saying with sex, I couldn't really get behind and I didn't really agree with. So they kind of spin off from him. They are called neo-Freudians. It's like they take the core part of it, but then they don't take all the other stuff. And they make the psychodynamic theory. So here, it's still talking about unconscious forces and childhood and stuff like that, but they're not doing free association. They're not, doing all that kind of stuff. The major people here, Alfred Adler and Karen Horney, and yes, that is how you say her name. And they were influenced from Freud's ideas, but they didn't like a lot of, like I said, some of his stuff about sex, some of his stuff about id-ego, superego. Probably don't know what that is yet unless you took honor psych. We'll talk about it in Unit 7. And some of his other things. They didn't want to just focus on childhood. They wanted to focus on the whole life. So they took the core of it and just spun it different. And that's what psychodynamic is. And you could find a psychodynamic therapist today and stuff like that. And like I said, they don't lie on a couch. They just talk to a person face to face like normal. All right. And then so psychodynamic and the one that's about to come up next in your notes, humanistic, are both called insight therapies because they give you insight to yourself. They're like introducing you to things about yourself that you had never thought of or considered or figured out on your own or, that kind of stuff. So humanistic, like I said, will be the second part of the next unit we talk about. But humanistic, if you remember back to the beginning of the year, all these four that we're talking about, the psychoanalytic, psychodynamic, humanistic, behavioral, and cognitive, all those four types of psychotherapies, those were the approaches to psych we talked about in the very beginning of the year in Unit 1. It's kind of just your lens in which you can look at psychology. It's not to say one's right or wrong. It's just we're all different, and we all just kind of tend to be drawn to one over another, or two together over some of the others. We like some, we don't like others. So it's just kind of like if you were going to be a therapist, you would practice therapy under one of these lenses, if you will. If you were needing to seek out therapy, you would kind of think about yourself and what your problem is and how you kind of respond to stuff, and you would seek out a therapy like psychodynamic or this humanistic or what's coming up in the notes, behavioral or cognitive, stuff like that. So Humanistic I always call the sunshiny approach. That's all about the person and their potential, their real self, their ideal self, stuff like that. So it's all about boosting your self fulfillment. And you did not have to write all these down if you didn't want to. Um, you can kind of like sum it up, you'll see. Promoting growth, not just curing the illness, taking responsibility, and it's things that you know about, not things that are uncovered, like in psychodynamic analytics. So you can see how these are different. Conscious thoughts more important than unconscious thoughts from the last one. The present and the future is more important than the past, your childhood. That's like how it differs from the two psycho ones we just talked about. Major people here, Carl Rogers and Abraham Maslow. Those will be the two guys we talk about with Freud in the next unit. Carl Rogers is a therapist who came up with something called client-centered therapy, and basically it's exactly like it sounds. First off, he wouldn't call the people patients, he called them clients. He thought that made it more on the same level, like the therapist isn't above the patient, or something like that. They're kind of more on the same level. So he called them clients, and he would use techniques that you'll see in a second, active listening, stuff like that. He had a genuine, accepting, empathetic environment, which is that whole unconditional positive regard you'll see. So he didn't try and be better or judgmental or like, I'm the expert, you need to listen to what I say. He was just kind of like, if you think about a parent, like a really good parent, just like there for you, just listening and just nurturing and going to help you figure it out and just kind of being your sounding board and not offering like all these suggestions, just kind of helping you figure out how you want to solve it, but like being there to support if you want to. So it's a non-directive therapy. He's not like directing and telling the person what to do. He stated that if the therapist is genuine and unconditionally accepts the person, then that person's going to have a deeper connection with them. And if they have a deeper connection with the therapist, that's going to allow them to have more self-understanding, more self-acceptance. So like if you can make a really good relationship with your patient, then you're going to allow your patient they're going to heal more because they get a lot from your relationship with them. And then that in turn helps them with themselves kind of thing. That was his theory. So he had active listening. So the tenets of active listening, like kind of paraphrase, like summarize what the person said, ask for clarification, like you say this, can you give me an example? Or tell me how you felt like that or something. And then you reflect on the person's feelings, like what they just said to you, if it sounded frustrating, or I can see why that really upsets you, that type of thing. So it's empathetic listening in which the listener echoes, restates, and clarifies what's going on. And so it's part of client-centered therapy type thing. And it's said to really help because the patient knows that you're just listening, like you're not judging, you're not in your head trying to like, sometimes you tell people a problem and they're just like telling you what to do to fix it. And you're like, I don't want you to tell me what to do. I just want you to listen to me, and it kind of goes along those lines. He also stressed the importance of unconditional positive regard, which is when there's a caring, accepting, non-judgmental attitude. And he thought, like I said, it would help the clients have a deeper self-awareness, self-acceptance, stuff like that. You got some videos you could watch. This video with Gloria, you should check out. This is kind of what made his approach with client-centered therapy famous because of like his interactions he would tape with patients and stuff. And so this is one of them. It's really popular. It's a really famous clip and stuff from psychological history. All right, so those were insight therapies. Psychodynamic thinks your problems subside if you gain an insight, and you can resolve these unresolved unconscious tensions. Whereas humanistics think that your problems subside when you get in touch with your feelings and you just kind of figure it out. Next up is behavioral therapy. This is a directive one. It's not an insight one. It's telling the person what to do. So this you do have a lot of background knowledge on because of Unit 4. Unit 4 was learning, classical conditioning, operant conditioning, and that's the tenets that this is based on. So you kind of would have had that for the 2 before. Had I already taught you Unit 7, so my bad on that. But behavioral therapy is a therapy that applies the learning principles. And you remember there's classical and operant conditioning. So when we go through the therapy, you're going to see types that go with classical conditioning and some that go with operant conditioning. So therefore, we don't really talk about any main therapists per se, but the 2 people who kind of founded the whole behavioral approach, Ivan Pavlov with classical conditioning and B.F. Skinner with operant conditioning, those are going to be your main psychologists associated with this approach. So proponents of the behavior theories, they doubt some of the healing powers of self-awareness from the insight therapies like humanism. They might say something like, yeah, you can become aware of why you're anxious, but you're still going to be anxious until you figure out how to fix your anxiety. So let's fix it. Like you got to they're more of a practical person, maybe more of your math, analytical people, that type thing. very objective, very much like, let's take the steps and fix it, and yeah, that type of thing. So they think it's behavior you learned, and you need to replace it with a new learned, more constructive behavior. So talking about classical conditioning techniques, remember that's the whole US, UR, CS, CR, and you're kind of moving your way through pairing new stuff together to get that response, the new thing. Well, counter conditioning is kind of like the opposite of it. You know, counter kind of means like against or opposite. So it's kind of doing that, like condition them back, opposite. You know, kind of go. If you got conditioned to get into a psychological disorder and to do something maladaptive, it's like rewinding it and conditioning them back the other way type of thing. So behavior therapies that use classical conditioning to evoke new responses now, so that you can that'll like trigger the unwanted behavior and stuff like that. So you can maybe get rid of the unwanted behavior, being reconditioned basically. There's two types of counter conditioning. There's exposure therapy and aversive conditioning. So exposure therapy is like it sounds, you just expose the person to something. So it's a behavior technique, and the two types of exposure therapy you'll see in a second, systematic desensitization and virtual reality. But it's a behavior technique that treats anxieties by exposing the people to the things that they fear and avoid, whether it's in real life with systematic desensitization or whether it's in virtual reality with like virtual reality therapy, you know, in their imagination. But you're exposing them to whatever it is. Now, this works really great with phobias, obviously, because you're scared of something. You get exposed to it over and over, then maybe you'll quit being scared of it. So, systematic desensitization, a type of exposure therapy that associates a pleasant, relaxed state with gradually increasing whatever that anxiety triggering stimuli is. So if somebody's like super scared of snakes, you get them really relaxed and you're gradually introducing snakes. Maybe it's just a picture. Maybe it's one on the other side of a room and you're just gradually getting to where they can be around a snake without having a legit panic attack. Now, a lot of us would say like, oh, I don't want that. I'm scared of snakes. Well, yes, but remember, this is someone whose life is getting impacted, you know, a true phobic disorder. They are, you know, maladaptive and all those things we talked about. So this isn't just me or you being scared and someone trying to get us over our fear. It would probably work with that. This is trying to get someone like to get their life back working, if that makes sense. Because they think, as you see, the thought is that you can't be simultaneously anxious and relaxed at the same time. So if you get a person relaxed and they're truly relaxed, you help them stay relaxed, and you can show them that stuff that would make them anxious, and it just won't make them anxious, if that makes sense. So you just gradually move them into actual situations and stuff like that in order to conquer their anxiety. Behavioral therapy also has virtual reality exposure therapy in it. So, sorry about that. I take a little break. So virtual reality is like if you can't do it in real life because it's too expensive, it's too hard, stuff like that. So you don't want to keep putting someone on airplanes. You do, you know, if they're afraid of flying, or someone with PTSD. That's what the picture's from. I think it was in the video on PTSD with psychological disorders, and you put them back into those situations to try and get them over their PTSD experience and stuff. Aversive conditioning is another type of counter conditioning, and it's when you associate an unpleasant state with, let's see, an unpleasant state with the unwanted behavior. So you get them to quit doing the unwanted behavior because you kind of pair it with something else like really bad. So for instance, your book talks about if you're trying to get someone who's an alcoholic to stop drinking, you would like pair their drink with something that would cause them to get sick or to be nauseous. So every time they drink, they get really nauseous. So then all of a sudden they don't want to drink anymore because we don't like being nauseous and throwing up, right? And so voila, they're not an alcoholic anymore. It does work, but then the criticism is like the person knows that you're just putting something in the drink to get them to throw up. I mean, they're in on it. That's how it's working. And so there's always the thought that if they wanted to keep drinking, they could just go do that without you. There's nobody to put anything bad in their drink, and then they can go on drinking alcohol and continue to be an alcoholic. So it does work, but the other side of the coin is like the person's in on it. You know what I'm saying? So does it always work, or does it like sustain or something like that? Let's see. And so there's a picture of it. And that's the example I was talking about with like putting the drug in the drink and stuff like that. And you can see it's classical because it's got the US, UR. That would be like, so the US was like the drug, which makes you sick. That's UR. The thing that kind of had nothing to do with anything was the alcohol, so it was getting paired together. And so now the alcohol is causing that new response of making you sick. The CR, the CS not making the CR. So these are opposites. In systematic desensitization, the goal is to substitute something positive for something negative, right? So it gets you to do something, get on an airplane. In aversive conditioning, the goal is to substitute something negative with something harmful. So this gets you to not do something. This gets you to stop drinking. So what do you want the person to do? Do you want them to do something? If so, you need to use systematic desensitization. Do you want them to stop doing something? If so, you need to use aversive conditioning. So it's kind of the same thing, just however you want to do it. Right now, let's look at the things for operant conditioning. So this is, remember, when it's voluntary, you know what's going on. This is the whole reinforcement or punishment, and then like the schedules of reinforcement, that's the thing. So therapists use positive reinforcers step by step to get you to do something. So that's what a token economy is. So we've all experienced these. I talk about on the next slide how I did in school. You've probably experienced them in school where if you answer questions right, stay in your seat all day, behave, raise your hand, not talk, not get your phone out, whatever it is the teacher wants you to do, you do that to give you something. And then you are like, oh, what's a piece of paper? This is you can like turn it in for something like, bathroom passes, hall passes, homework passes, whatever means something to you. So while a little blue piece of paper she gives you every time you raise your hand might not mean anything to you, you don't crumple them up and throw them away because you know once you get 10 little blue pieces of paper, you can get something that does mean something to you. And so that's what it's looking for. And they'll use that in therapy. They use that in like mental institutions to get people to get up, to make their bed, to take a shower, grooming, come down and eat in the cafeteria, like whatever it is they want the person to do, they'll like reinforce them a little bit along the way and give them these tokens, and then they can, exchange the tokens for free time or TV or, whatever the system allows for. And so that's just me explaining what I just kind of told you guys. And that is pretty much it for behavioral therapy. Moving into the fourth one, cognitive therapy. So if you remember back at the beginning of the year, that approach has to do with your mind. It's different than biological. Biological is your brain. You can see medically all those things. Cognitive, you can't. Cognition's your mind. It's your thinking. It's stuff you can't see. You can't get your thoughts, your dreams, your memories, that type of thing. So it's your mind, not your brain. You also have a lot of backstory on this because this was Unit 5, the cognition unit, with thinking, memory, thinking and language, memory, and intelligence. So that's kind of where that goes. So it's therapy that teaches people new, more adaptive ways of thinking, and it's based on the assumption that our thoughts intervene between our events and our emotions. So they think our thinking, these types of psychologists think our thinking influences our feelings. So therefore, if you can change the way we think, then you can change the way we feel, and you could maybe eliminate a psychological disorder. It's mainly with a guy named Aaron Beck. That's the main therapist associated with the approach. And so he would use his therapy to treat depression. He would just try and reverse the client's negative thoughts about themselves, about the situation, about the future, whatever it is the person was kind of like dwelling on negatively, he would try and flip it. And he found that if he could flip it and quit get them to dwelling on stuff negatively and reverse that irrational thinking, like reveal to him at first like you're being irrational and then kind of reverse it, he could like get them, help and stuff like that. So instead of being like, oh, I lost my job, I'm worthless, I'm hopeless, and now sliding into depression, it's like, oh, I lost my job, but it's all right. Maybe it wasn't a good fit for me. I deserve something better. I'll find something else, and then not sliding into depression, changing the way they think. Then cognitive behavioral kind of goes with cognitive, but it's also kind of its own too. And it's where you combine those things. So you change the thinking, but then you also like try and change the behavior as well. Next up would be group and family therapies. So they're not one of the 4 I listed earlier because you can do any of those as a group therapy or as a family therapy. You can do behavioral, psychodynamic, stuff like that. So it's just kind of more of a way of doing therapy. It's just like it sounds. You just do it in a group instead of alone. It's, of course, if you do something in a group, you're not going to get the same degree of involvement with the client. One-on-one's going to be way more involvement than if you're in a group of 5, and that's going to be way more than if you're in a group of 10. So it just kind of depends on what you're looking for. And the benefits are it saves time and money. Like if you go to a gym class, that's a lot cheaper than if you had a one-on-one personal trainer. It also provides a social lab for exploring social behaviors and kind of seeing what's going on with the disorder, developing social skills, like talking about something that you might not want to talk about because other people are listening. But it does allow the person to see, I'm not the only one. I'm not the only one who feels like this. There's other people with my problems. And here's kind of how they're dealing with it, struggling, how they're helping themselves. Maybe I could try that, to get new ideas and approaches. And that's feedback, they can learn from each other as well. Family therapy is a type of group therapy in which the group is your family. And so it looks at the family as like one whole system. Um, and so it's not, people aren't an island. You know what I'm saying? It's not just you. Like, this is how you affect your entire family and how your entire family affects you and your psychological disorder. Like, are they doing things that are perpetuating the psychological disorder? Or is your behavior with psychological disorder like perpetuating problems in your family? It does the whole group, if that makes sense. There's also self-help groups and support groups. There's tons of them out there. Probably the most famous one is Alcoholics Anonymous, AA, and they have their famous 12-step program that a lot of other self-help groups have kind of copied this type of like step, which goes from like acknowledging there's a problem with step one to like helping people and like helping treat other people with it in the final step. So, evaluating these psychotherapies prior to 1950, a psychiatrist, which is, you remember, out of a psychiatrist to psychologist, the psychiatrist is the one with the medical degree, the doctor. They were the primary providers of mental health care for people. After that, psychologists kind of come about, and so psychotherapy comes about, and you have a humanistic or a behavioral psychologist. And there's tons listed here that are out and about today. Put your quote there. And then, is it effective? About 90% of people reported feeling better after therapy, and about 80% of therapists believe that their people got better. But then it's like, well, can the data be misleading? Like, could 90% of those people have gotten better over time, even if they had never went to therapy? Or that 80% of therapists that thinks their people improved, did they all improve? Like, if the person quit coming, did they ever really tell them why? Sometimes you're just like, thank you, and leave, where you're like, oh my God. And you don't really tell the person, so they don't ever know. So this guy named Hans Eisnig did this a pretty famous study in which he found that 2/3 of patients improved from therapy, which is really good. But so he got two groups of people that went to therapy and people who didn't. Of the people that went to therapy, 2/3 of them actually improved. But what he found is, of the people that didn't go to therapy, 2/3 of them improved too. So it's kind of this like, does it help you, or like would time and yourself like help yourself? So we look at these things called meta-analysis. Okay, so you got that definition right there, and it's where we combine a lot of different research into one to get like one bottom line result. So here would be it. So what he found is that people were helped slightly more from therapy than not. So about 80% of people that went through therapy were better with treatment, whereas about 50% who did not go to treatment, they were better. So you can still get better on your own, but there was a more of a success rate with it, looking at a meta-analysis. It's also cost effective. If you think about having to pay a little bit up front to save you a lot in the long run, it's definitely worth it, right? So if a person can, kind of manage their psychological disorder, that could save them in the long run, because maybe they go to work, so they get money and they get a paycheck and they don't lose their house and they don't, like all those things that would add up. Or it can save someone from being a criminal and then we have to house them in jail for however many years. Or, it helps businesses because people are more efficient and they work better. And so the business makes more money. So while it does cost to go, it seemed to believe to be that's a small investment and a greater outcome. And statistics have failed to say which type of psychotherapy is best. So, like I said, it's just what works for you, what you align best with. If you're the therapist or if you're the person seeking therapy, you just kind of got to go with how you. So, for me, it would probably be like a humanistic, or maybe even a behavioral or something like that. I'm probably not going to be a super on the psychodynamic thing, because that's just not the one I feel like I connect with the most, which is fine. It doesn't mean it's worse or anything. It's just, if I needed help, I need to know kind of which direction to go. If I was going to help you or help someone, I would probably help you more in like the figuring out your potential and who you are type of way. That's just kind of the way I'm wired. So that's what that means. And clients seem to be equally satisfied if they're treated by whatever type of professional: psychiatrist, doctor, a psychologist, a social worker, treated individually or in a big group. There tends to be a little connection between the client's experience, the training of the person, the supervision, the licensing, their client's and their client's outcome. No. That shouldn't be client's experience. That should be there's little connection between the therapist. I need to change that. That should say between the therapist experience, training, supervision, and licensing, and the outcome for their client. I can get this black box going. Come on, box, go away. There you go. And the client's outcome. So between the therapist experience, training, supervision, licensing, and the client's outcome. All right, so kind of what they're known for. Psychodynamics known for helping people with depression and anxiety. Humanistics known for helping people with mild to moderate depression. Behavioral is best for things like phobias and compulsions, anything that's kind of a behavior, you know, that you're doing, the compulsions or the behavior, like washing your hands that go along with like the OCD, the obsessive thoughts of like I'm dirty. Cognitive and cognitive behavioral therapy help with anxiety, PTSD, and depression. Not to say you couldn't use any of them for anything. That's just kind of what they've shown higher success rates with. Then you got evidence-based practice that basically says that the clinical decision making that integrates your best available research with clinical expertise, patient characteristics, preferences, stuff like that. And then that kind of goes along with the therapeutic alliance, which is a bond of trust and mutual understanding between a therapist and client. So if you can trust the person and you know they're not judging you and they're keeping your information confidential and not talking crazy about you or crap about you behind your back, like you're gonna do better with someone you trust and like. That's kind of basically what that therapeutic alliance is. There we go. Whoops. So does it help? Yeah, because it gives help to people. I mean, if you're suffering from a psychological disorder, especially a serious one, you're probably pretty demoralized. You're feeling really down, really bad about yourself. And so you probably are excited about therapy because you think, why not? Let's give it a shot. I really think it'll help. It helps so and so. This will work wonders for me. It'll give you new perspectives, just like things you haven't thought about before. Like, oh, okay, well, if I do it that way, yeah, that does make sense. Like, I can see why, like that kind of stuff. And empathetic, trusting, caring relationship. Like maybe they don't have a lot of these. Sorry. Okay, trying to do like two things at once. Maybe they don't have a lot of relationships like that, so it's really hard for them. And so if they get one with their therapist, that really helps them. All right, and then culture and values. So everyone's different cultures, different values. So if you know, someone from an Asian culture where they're more community minded and collectivist comes to America and gets therapy where we're more individual and individualistic and stuff, you know, that might not help their problem because we're talking about you, but their whole life they've grown up like we. So it's not, they're not connecting. You know what I'm saying? If you don't have a connection, you're not going to probably get helped as much. So therapists do differ, and so that's evident when two different cultures meet. And so the APA, the American Psychological Association, does a lot of like cultural sensitivity training, trying to like, you know, let people know when you're working with people from different cultures, here's how you can best reach them. But maybe that explains why people who are minorities, especially immigrants, don't seek a lot of professional therapy or mental health. And if they do, they usually terminate it early. They stop before, you know, they should, that type of thing. All right, part 2 of your notes is the biomedical therapy. So I just got done talking about all like the psychotherapy, which is like counseling and stuff. So now I'm going to talk about biomedical therapy, which is like all the drugs and surgeries and procedures and stuff. Again, make sure you watch the crash course. So biomedical therapy is prescribed medications or procedures that work directly on your physiology. So now we're looking at the more biological approach to psychology. You know, so if you're a sciencey person or a medical person, you're probably, you know, this is where you're finding yourself to be more aligned. So you can change the person's brain functioning by altering its chemistry with drugs, affecting its circuitry with electroconvulsive shock, magnetic impulses, or doing a psychosurgery, or even looking at just how you could change someone's lifestyle. So, see, it wants to work, sometimes it doesn't. So this is just me kind of organizing it like I did on the last one. So these are your main 4: drug therapy, brain stimulation, psychosurgery, and therapeutic lifestyle changes. And then I'm putting the types of drug therapy, the types of brain stimulation, the types of psychosurgery. Really good video right here if you didn't watch me do it where I broke it down and gave you time to write. I talked about that. Really good video by Philip Zimbardo, who does a lot of videos about all the psychological concepts, and he's your guy from the Stanford Prison Experiment, if you remember him. So drug therapy is the most common type of biomedical therapy, and it's called psychopharmacology because, like a pharmacist, that's where you get prescription medicines and stuff. So psychopharmacology is the study of prescription medicines that affect your mind and behavior. And talk about how you find out if something works. Going back to like unit 1, you have 2 groups and one gets it and one doesn't. You compare your results. So all those things we talked about and with methods of unit 1, like you would have to do random assignment to get your big group. Or no, I'm sorry, random sampling to get your big group. Once you get your big group, you'd have to do random assignment to see who's going to be in control group, who's going to be in the experimental group. Experimental group gets the drug's the independent variable, control group doesn't. And then you kind of look at the effects of the drug as the dependent variable, and that's how you compare. So if you're in it and you're taking a drug, you don't know if you're getting the real drug or the fake drug. So remember, the control group that's not really getting the medicine, they get something called a placebo, because you can't just give half the people a pill and half the people not. Like, they'll catch on. You know what I'm saying? So everyone needs to like put something in their mouth. They think it's a drug study. And also, the researcher doesn't need to know who's getting the real one or the fake one. So when the people don't know and the researcher doesn't know, that's 2 different things. That's double. And both participants are blind. They don't know who got what. So it's called a double blind procedure. And you have like a third party group, who assigned it out. And at the end, they give the researcher the data or the list of who was in what. So the researcher can look at all the data they collected and be like, oh, the drug works. Or like, no, there's no difference or anything like that. And so that was all from unit 1 with research methods. So first type of drug is an antipsychotic drug, very powerful drugs. Talk about while we go through all these are nothing that would ever need to be mixed with alcohol, recreational drugs, even like abusive over-the-counter drugs, like, because these are very powerful drugs. These manipulate how your brain works. So these are not things you want to combine with other stuff. That's how you have like deadly outcomes, unfortunately. So these are used to treat schizophrenia and other forms of severe thought disorder. The examples of these are Thorazine and Risperdal. Thorazine is kind of how it started. Risperdal is a more common, more current, newer one. And I think when you read about or watched the video of schizophrenics, if you watched that in the last Google Slides, the 2020, they were talking about the person was getting Risperdal. They dampen the responsiveness to irrelevant stimuli because the person has a lot of stimuli in their brain because they're having those auditory hallucinations. They're paranoid. They're, all this stuff's going on in their brain that's not real. And so it kind of helps to like, push all that out. They're similar to the molecules of dopamine, and they occupy the receptor sites and block its activity. Because if you remember, having too much dopamine leads to schizophrenia. So it kind of like keeps the brain from getting flooded with dopamine, basically. But there's some side effects because having too little dopamine leads to Parkinson's disease, and that's when a person kind of has the shakes, like tremors and twitches. So this could lead to that going down so much the level of dopamine. Combined with therapy and family support, it has allowed schizophrenics to leave mental hospitals and live a normal life, which is good. Anti-anxiety drugs are drugs used to control anxiety and agitation. You've probably heard of these before, Xanax and Ativan. They work by depressing the central nervous system. So if you go back to the beginning of the year, Unit 2, we talked about the central nervous system, the center of our body, controlling kind of a lot of those major functions of our body. And so you want to calm it down, like the breathing, the heart rate. Downside is these can become addictive, but they're pretty commonly prescribed drugs. All the time in pop culture, like but I think they can also be easily abused, unfortunately, too. Antidepressants are up next, and they're just like they sound. They try not to depress you. But if you notice in your definition, I have that it's used to treat depression, but I also have it's used to treat anxiety disorders, OCD, and PTSD. That's because the newer antidepressants like Prozac, Zoloft, Paxil, stuff like that, there's something called SSRIs, which stands for selective serotonin reuptake inhibitors. And basically it keeps your body, like it kind of regulates the amount of serotonin and stuff like that. And it keeps serotonin from going back up into, you'll see it in a picture in a second, back up into the first axon. And so by doing that, they can also help with people's anxieties and OCDs and PTSD. So you may hear someone with PTSD or OCD or anxiety getting prescribed an antidepressant. You're like, what? The person's not depressed. Well, it's because chemically it's kind of doing the same thing. So here's an SSRI. So this takes you back to Unit 2, the pictures we did with axons and dendrites and the little space in between where the axon of one neuron touches the dendrite of another. The space is the synapse or the synaptic gap. And so you can see the neurotransmitters in yellow passing out the axon of this light blue, going across the synaptic pathway, and they're going to go into the dendrite of this kind of darker blue or purple. Now, normally that happens fine and you're good. Someone with, a psychological disorder, what happens is they don't all get, into the new dendrite. And so they're kind of floating around the space, and they start going back up into the axon and they get reabsorbed. If they get reabsorbed in the axon or reuptake, same thing, they're not getting used. So basically there's not as much serotonin, and so serotonin's the emotional one. So someone who has less serotonin has depressed mood, and that could be depression. So what happens is the medicine goes down here, and the medicine kind of blocks it from going back up into the axon. So the serotonin has to go into the new dendrite, or it has to stay in the space and stuff like that. So that means there's more serotonin. The more serotonin, the more the mood goes up, gets the person out of depression. And I think that's what I just kind of explained here. Yeah. And a lot of times it takes several weeks to feel better. It's not something that is really quick. It's something that's trial and error. They have to figure out how much and which things. Zoloft, Paxil, like which thing works best for you, how many milligrams. Do you have mild depression, moderate depression? Even it factors in things like people's size and weight. So it's a lot of trial and error, but once you kind of get the right concoction for you, then it's usually very helpful. But it takes a while. So people have to be patient, which is sometimes kind of hard when people are trying to come out of this depressed state. Next drug we're going to talk about are mood stabilizers. They're mainly for people with bipolar. And the main one is lithium. Extremely, extremely powerful drug. Arguably probably the most powerful drug that we see on here. Something you would definitely not want to mix with drugs or alcohol, like recreational drugs, over-the-counter drugs or alcohol. Be very deadly. But it helps people who are bipolar to kind of manage and not be super high in the mania or super low in the depression, which also can lead to decreases in suicide, because bipolar has the highest instance of suicide out of all the psychological disorders. All right, now let's talk about the second type of biomedical treatment, which is a brain stimulation. So the first one is ECT, electroconvulsive therapy, and it's where the person and it usually is for depressed people, but it could be other types of psychological disorders, are given a brief electrical current. They'd be sent through the brain. Nowadays, the person is under anesthesia, but it didn't used to be. So it's very controversial because, it was really big, maybe not quite 100 years ago, 50 years ago, stuff like that. The person would be wide awake. They would be strapped down because the electric shock made them like flail about, and they could like fall off the table and stuff. So you like strap their legs, strap their arms, but their hands and feet, they're still jolting around everywhere. And you put 100 volts of electricity through their brain. And it was labeled as very barbaric. I mean, to watch it is just, oh man, it's terrible. Today it's much gentler. The person is put under anesthesia and given muscle relaxers. So you don't even have to strap the person down anymore, because they're not going to be flailing about or anything like that. It lasts about 30 minutes. And when the person awakens, they feel no pain, they have no brain damage, but also they have no memory of it, which is kind of interesting. After about 3 sessions of 2 to 4 weeks, about 80% of patients improve. Really, really high. So ECT is very controversial, but surprisingly has a very high success rate, It's especially been helpful for people with very severe depression that like drugs couldn't help. So even the SSRIs, like it really didn't matter. It couldn't pull the person out of their severe depression. And people don't know exactly how it works, but it works. Here's a picture of it. So you can see the person's not strapped down nowadays. They got like the blood pressure cuff. So it's monitoring, monitoring their heart, monitoring their blood pressure, monitoring their oxygen. Then they've got, they're getting the anesthesia and the muscle relaxer, like intravenously. It's, like the needle to port into the skin. And then, they're just delivering electricity straight to the brain. Here's a clip from the past. Now, it's kind of hard to find real clips of the past, because I guess back when they were doing it, they weren't really filming it much. So this is a clip from a movie called One Flew Over the Cuckoo's Nest, kind of show you what it used to look like. And I'm sure you could probably Google and find more stuff. Here's a clip of what it looks like today. And so these are very interesting. I think you should try and check those out if you haven't. The other type of brain stimulation is RTMS, which is repetitive transcranial magnetic stimulation, in which they kind of put a magnet on your head and they just like send pulses of magnetic energy, magnetic waves, like into your brain. The person's awake. There's no feeling. You can see like the picture right here. Kind of makes like a clicking noise. And I think the video for schizophrenia, the 2020 video back in the psychological disorders PowerPoint. I'm sorry. And the person's awake, no risk of seizures, memory loss, other serious side effects. Again, kind of unknown how it works. There's a video on it. And then you got deep brain stimulation, which is where it's basically, they call it in the video that I got linked here, like a pacemaker for your brain. So people will get pacemakers attached to their chest or heart, and it's to keep their heart like beating regularly and not to get irregular stuff. It's kind of like that for your brain. And so it kind of goes down into where the frontal lobe meets the limbic system, because that's where our emotions are housed, and kind of helps with that. And about a third of people respond very well, and about a third of people respond moderately well. So it's got about a 2/3 success rate. The third type of biomedical treatment is a surgery. And since it's a surgery to help you psychologically, it's called a psychosurgery. So a surgery that removes or destroys brain tissue in an effort to change behavior. This is the most drastic, this is the least used biomedical technique. It's irreversible and it's controversial. And if someone messes up, they mess up, and that's your brain and that's your life and that controls you. I mean, it's very risky and stuff like that. There are some today that are used, like really precise surgery to help people with seizures or OCD, to help people with Tourette, stuff like that, but it's not very common at all. One that is pretty much not done at all today, but was very controversial because it was unfortunately very popular 100 to 50 years ago, was the lobotomy. And so if you heard me talk about it in the other video where I stop and let you write down notes, I talk pretty extensively. Be careful if you Google, videos and pictures are pretty graphic, but yeah, you see the picture down here. It's called ice pick surgery. So the person would be awake, they would go up through the eye socket into the brain, and they would basically, I say make an incision, but it was kind of just jamming the ice pick around until you just like destroyed all the brain tissue, because they wanted to destroy the connection where the frontal lobe went to the center of the brain, like the limbic system, the emotional center. And so they would do that. And they thought, like, oh, if someone's like uncontrollably emotional or violent, has these, quote unquote, getting crazy or something like that, you can sever the connection, the person will be fine. And they were doing these like freaking left and right in America 50 years ago or so. It came from, couldn't remember in the other video, I meant to look it up, I think like Europe or something. It was hailed as like a miracle treatment. I mean, they were doing thousands and thousands of these, tens of thousands. It was crazy. But it's not that good. And it would leave the people emotionless, robotic-like. It would affect people's mental ability. I mean, think of how much is housed in your brain. People lost like some motor functions, because you think of the motor cortex and all that's there. They lost their personality because that's housed in your frontal lobe. We talked about that with Phineas Gage. It was all types of drastic side effects. But again, irreversible. And there's nothing you could do. And probably the most famous person with it your book talks about is Rosemary Kennedy, who got one that is John F. Kennedy's sister. And the dad, went behind everyone's back and got her one, and it didn't turn out well. And she had not only he basically said, she was very emotional. I don't know if she had a psychological disorder or not, but she was very not kind of keeping up with the heirs of the family, as in like, we're elite, we're smart, we're refined, we're trying to raise the next president of the United States, And she was kind of a lot. And so I think she would have outbursts or wild or something like that. And so he had one of these done, and that went away, but also like a lot of her like mental abilities. And she went to an institution for the rest of her life, and her sister ended up founding the Special Olympics because seeing the state that her sister was in. So there was a good thing to come out of it, the Special Olympics, but it was a pretty terrible situation and story. And you can read all about it online. It's probably the most famous lobotomy there is. And then you got the fourth thing, which is therapeutic lifestyle change. So a bunch of things in our lifestyle could also help us. Exercise, nutrition, diet, relationships, good ones, getting out of bad, toxic ones. Recreation, relaxation, religion, spirituality, sunlight exposure, sleep. Like, you're sleeping well and you're eating well and you're exercising. Like, things like that can physically change the chemistry of your brain and stuff. And they say like exercise and sunlight exposure, two of the biggest things that can help a person with depression and things. So it promotes physical activity and social engagement to treat and prevent psychological disorders. So preventing psychological disorders, as you know, it's better to prevent something than to treat it. If you could ever stop it from happening, that's a whole lot easier than trying to fix it. And that's what community psychologists actually try and do. But the last two things you're going to talk about are resilience and post-traumatic growth. So resilience is when, like, after something, you like rebuild yourself, like become better. You know, the examples like New Yorkers after 9/11, they were strong, they rebuilt, they were patriotic, they were, together, they were unified. So it's like when you come out of a stress and you recover from the adversity. And similar is something called post traumatic growth. And this is like after going through something, some type of life crisis, some type of challenging circumstances, you're kind of better off and you can help other people. So, kind of think about like if a cancer survivor, they're healed, they're cured, and they have a greater appreciation for life and they go out and do all this stuff to help, that type of thing. All right, so that's it with your therapy notes. Hope you enjoyed the review. See you guys later.